To continue on with the CAD, or coronary artery disease, like I said, it can lead to a myocardial infarction, an elevated ST, and we call this STEMI, for myocardial infarction with ST elevation. If you look at this picture, I'm trying to use it to explain to you why we see an ST elevation. If we're talking about the picture for letter B in both of these pictures, the ST in the top EKG is using the precordial lead number 5 as the leading lead. And in the bottom picture, you're seeing an area of the left ventricular wall that has suffered trauma. That basically was an MI. Now, those cells will not be able to conduct current. They won't be able to allow ions to flow across the cell membrane, which means they're not going to permit any flow of ions. They're not going to alter their membrane potential. So they're going to hold on to a positive surface charge. That's where the vector is going to point. I'll remind you that the vectors always point to an area of positive surface charge. So we're going to see this ST elevation as a result of that, because those vectors you see in this picture point outward. And this will also mean that we're going to see a left axial deviation, or LAD. Again, this LAD is going to point upward towards this area along the left ventricular wall. We can use cardiac markers to ID an MI. We can monitor the levels of myoglobin, and it's important to note that with all these cardiac markers, they are basically proteins that have been pushed out of the cell because it's been damaged. So myoglobin is an intracellular protein that helps cells store oxygen. It sounds a lot like hemoglobin, and it does bind oxygen. But this is not specific to cardiac tissue. Skeletal muscle also has myoglobin. So it would be nice to look for more specific markers like creatine kinase MB isozyme. That is a specific marker for cardiac muscle. Even better are troponin assays like TNI and TNT for troponin I and troponin T. Those are also cardiac specific. How can we treat CAD? Well, we want nitric oxide. That is the intrinsic chemical signal for the coronary arteries that's primarily used to cause them to vasodilate. This would certainly help with that occluded blood vessel. Nitroglycerin is an extrinsic drug, but when taken sublingually, it will lead to an internal release of nitric oxide. So nitroglycerin leads to more nitric oxide release in the endothelial cells lining the coronary arteries. That will help with vasodilation and restore blood flow. We also can give beta blockers so that the heart does not respond to sympathetic output that could lead to tachycardia and exacerbate the ischemia. We can give thromboxane A2 inhibitors. I'll remind you that that is a vasoconstrictor made by the COX-1 enzyme in platelets. So aspirin is an antiplatelet. We can also give ACE inhibitors because the kidney is going to initiate the RAA pathway. The reduced coronary output as a result of the heart remodeling and not being an effective pump on the left side will be detected as decreased renal blood flow by the juxtaglomerular cells. Now, what else can we do for a person with coronary artery disease? We can do surgical treatment. Usually this is reserved for once the coronary arteries are about 90 to 99% occluded. The surgical treatment we can do is a coronary artery bypass graft, also called a CABG. And this, to do a traditional CABG, can cost about $20,000. They use the great saphenous vein usually. The problem with using the saphenous vein is that eventually, it will develop problems and will need to be replaced. The reason why it will need to be replaced is because CABG does not alter the progress of coronary artery disease. The person still has an underlying issue with accumulating fatty streaks. So the angina will return, and 50% of the vein grafts are going to be closed in about 10 years after the CABG. So they will have to do another surgery. and they'll have to also take the saphenous vein and invert it so that the valve veins don't prohibit blood flow. And again, this is a very expensive procedure because the person has to be on a heart-lung pump. Now, an off-pump coronary artery bypass is basically the same thing, but they don't slow the heart down and they don't put the person on a heart-lung bypass machine. And if you want to see how they do that on this slide, I've given links to 2 videos, but also in your Blackboard I gave you a link to watch how a CABG is done and an off-pump CABG, and along with that last video, the off-pump CABG, there's a discussion about the mid-cab. The mid-cab is a minimally invasive direct coronary artery bypass. It's so cool. They can take the internal mammary artery or thoracic artery, and this internal thoracic artery is actually the first branch off of the subclavian artery. So they take it off the anterior chest wall. They only need one, and that's okay because there's one from the other side, so the chest is getting adequate perfusion. They just have to do a cut through the person's left side. They don't have to do a sternotomy. They can just simply pull away that internal mammary artery and bypass the anterior interventricular artery, as shown in this picture from your textbook. Now I'd like to move to some problems with fetal heart development. In this first one, we're going to start out easy. It's the patent ductus arteriosus. Normally in the fetus, the ductus arteriosus is a right to left shunt because the pulmonary circuit has a high resistance because the lungs are collapsed. The blood would flow from the pulmonary trunk to the aorta, and that bypasses then the pulmonary circuit. But once the child is born, as shown in this picture, if the ductus arteriosus remains open or patent, now the resistance in the pulmonary circuit is very, very low, and the blood will flow from an area of high pressure to low, which means now the blood would flow from the aorta down to the pulmonary trunk. This means the blood is back flowing from the aorta back to the lungs repeatedly. That's obviously a waste of circulation. During this time, the net cardiac output decreases to the body because some of it is backflowing to the pulmonary trunk. And the kidneys, well, they're going to detect less blood volume delivered to them. Therefore, they will release EPO and initiate the RAA pathway. Now, in this situation, the baby will have both left and right ventricular hypertrophy. First of all, right ventricular hypertrophy is normal for a newborn because the right side of the heart has been contracting against the high resistance in the pulmonary circuit. But it will be maintained because the right ventricle now having to push harder to overcome the backflow of blood into the pulmonary trunk. The left ventricle will also have hypertrophy in order to accommodate the new blood volume, but also to generate a greater force of contraction to ensure greater stroke volume in order to get cardiac output back towards normal, because again, some of that blood was backflowing into the pulmonary trunk. As an end bullet, I want to tell you that there is a characteristic cyanosis that the baby presents with, because of where the ductus arteriosus links to the from the pulmonary trunk to the aorta, specifically along the aortic arch. The baby will present with a bluish or cyanotic tinge on the left side of their skull, left upper body member, and lower member. But the right side of the skull and the right upper limb will appear pink and healthy. And the reason is, and you should review the anatomy, the pulmonary trunk attaches to the aorta through the ductus arteriosus somewhere close to the left common carotid and the left subclavian artery. In other words, the brachiocephalic trunk does not get mixed with the poorly oxygenated blood, and the brachiocephalic trunk is the one that is going to ultimately serve the upper right member and right side of the skull. In your textbook, they classify these newborn heart issues as either cyanotic or non-cyanotic. Well, tetralogy of flow certainly leads to cyanotic babies, blue babies as they're called. Now, tetra means 4, so there are 4 problems in tetralogy of flow. Number 1, there is pulmonary valve stenosis. This means there's going to be high resistance for any blood trying to be ejected from the right ventricle into the pulmonary trunk. Number 2, there is, as a result of that, a thickened right ventricular wall, meaning right ventricular hypertrophy. Third, there is a ventricular septal defect, which is where blood can go from the right ventricle to the left. This is going to be a right to left shunt, of course. And the aorta can actually come off that septal defect, which means it's right there ready to pick up the blood straight away from the right ventricle, as well as from the left. So the blood is not going to the pulmonary circuit. It's simply going from the right ventricle to the, quote, left and straight to the aorta, which is why we call it a right to left shunt. Now, it's interesting that a physician, a cardiologist, can go in and either insert an artificial patent ductus arteriosus or give the baby prostaglandin E2 to maintain a patent ductus arteriosus, and here's why. It's like the blood is going to be allowed to backflow behind the obstruction. So if you look at number 1 on this picture here, you're seeing the pulmonary valve stenosis. Well, if there's a PDA connecting the aortic arch to the pulmonary trunk, the blood that's being ejected from the right ventricle straight to the aorta, well, some of that blood is going to backflow to the pulmonary circuit and reach the lungs for oxygenation. So that can be a temporary fix, and don't get me wrong, it's not 100% curative, of course. The baby is still going to have cyanosis. This is just a little bit of blood backflowing, but it's enough to buy the baby time until they can get strong enough for open heart surgery to fix their congenital defects. Obviously, the baby is going to present with right ventricular hypertrophy and certainly right axial deviation. Now, I'd like to tell you about transposition of the greater arteries, or TGA. This cute little guy here, look how blue he is, clearly cyanosis. His name is Karsten, and he was born with TGA. Now, I love this story because one of my favorite students, Jessica, was pregnant with Karsten when she was in my anatomy class. Well, let's first talk about what exactly is TGA. If you look at that bottom picture in the little dashed circle that you can see, you're seeing that the aorta is coming off of the right ventricle and the pulmonary trunk is coming off of the left ventricle. Now, this means that the pulmonary circuit, when Karsten was not born, had high resistance, so it was occluded. Now, the left ventricle in Karsten was trying to pump blood to a circuit that had high resistance. Some of that blood was shifted from the ductus arteriosus into the aorta. Now, when he wasn't born, none of this was a big problem because his oxygenated blood was coming from the placenta. So blood returning from the placenta to the umbilical vein would reach the right atrium, to the right ventricle, and then go straight to the aorta, to the systemic vessels, and deliver oxygen. So in utero, Karsten was fine. But then, what else happened to Karsten and Jessica? As if the TGA wasn't enough? Well, Karsten started to develop hydrops fetalis, which basically is edema in the fetus. And again, it comes down to your Starling forces. It's just a question of which one causes Karsten's edema, and the edema was causing his heart to fail. Or was his TGA a sign that he had other congenital heart problems, and his heart was getting weaker, and therefore the edema was a result of that? One day, Jessica tells me she's going to the hospital to deliver a dead Karsten because his heart rate was progressively slowing. On a hunch, before her doctor induced her labor, he tests her blood, test her amniotic fluid, I should say, for parvo. Jessica had been exposed to the parvovirus, the B19. Apparently one of her nieces or nephews had had it. Most women are immune. 50% of them are. Those that aren't, they have to come in contact with the virus at a certain point in their pregnancies. So, less than 5% of all pregnancies are affected. The women have to be exposed to the virus in the first half of their gestation. And this was Jessica. She was not immune, and she was in the first half of her pregnancy, and she happened to be one of those 5% where the virus affected her and Karsten. The virus attacks red blood cells. This causes profound hemolysis within Karsten. Now I'll remind you from anatomy and physiology that during fetal development, blood cell synthesis occurs in the liver and the spleen. Albumin synthesis also occurs in the liver. If there is a profound hemolysis, the macrophages in the liver are phagocytosing the damaged or dying red blood cells and releasing the amino acids and iron so they can be reused. Well, all of that happens in the liver. So in Karsten's case, the virus was causing profound hemolysis. Now his liver was being overtaxed with cleaning up all those destroyed red blood cells, but also making them. Well, something has to give. His liver started to shut down albumin synthesis. This is going to mean a decreased capillary colloid osmotic pressure, which means less pressure to retain fluid within the capillary bed, which means he started to present with the hydrops fetalis. Right when Jessica was ready to let Karsten go, Jessica's doctor gets back her amniotic fluid results and she pops positive for the parvovirus. So now that they know she's infected with parvo, now they know why Karsten has the edema. So they gave Karsten an intrauterine blood transfusion, and eventually the edema started to subside. So Karsten lived, and Jessica delivered him at around almost 37 weeks of gestation. Karsten had a septal defect, which worked in his favor when he was born because some of the well-oxygenated blood from his left ventricle could now enter his right ventricle. That means some of the blood gets up into the aorta and to the systemic circuit. Again, TGA means that Karsten's aorta was coming off of the right ventricle. Additionally, if you look at the left side of this picture, you're seeing the coronary arteries are still with the aorta, as they should be. So the heart is getting oxygen-poor blood, and the heart needs a robust supply of oxygen. So they can actually do a procedure where they insert a catheter through the femoral vein and feed that catheter all the way up, or some other large vein near the heart, and they feed it all the way into the vena cava to the right atrium and do a balloon atrial septostomy, which basically means they're breaking another hole into the interatrial wall. This is to allow blood to flow from one atrium to the next, to allow more blood mixing. Prostaglandin E2 can also be given to maintain a patent ductus arteriosus. So what's the point of all this? To allow more mixing of blood, because blood is going to flow from high pressure to low. We want the blood to be mixing as much as possible until the baby is strong enough to have the open heart surgery. As I said, Karsten lived through all of his surgeries. In this left picture, you can see his open chest. They just put a little piece of tape around that open wound in the early days of his surgery. They wanted to make sure everything was good. It's easier just to take off a piece of tape than to open up the sternum in case they needed to go back. But look how nice and pink he looks in this picture compared to the earlier one I showed you. I had the pleasure of meeting him one day, and he is just the happiest little nugget I have ever seen. You could never tell he had such a rough development. He had no brain damage at all from all of his surgeries or his experiences in utero, even from the parvovirus. He's meeting all of his developmental milestones. He is truly a miracle, and he is a joy to be around. Lastly, I'd like to tell you about long QT syndrome. Now, this is the only EKG issue that I've picked from your textbook. It's one that I think you've probably heard of indirectly from newspapers. Have you ever been reading the newspaper or watching the news and they talk about a child who was at a sports activity and dies on the field? You know, the football player, the basketball player, the cheerleader even. And it wasn't a hot day, and the coach gave ample times for breaks and drinks, but still the child just dropped dead, and no one knows why. Well, chances are it was a channelopathy. Most notably, a famous soccer player recently had this. He literally dropped on the soccer field and had a heart attack. It was Fabrice Muamba. Turns out he had a slightly different type of channelopathy, a different issue with his heart, but it still applies to what I'm telling you. Long QT syndrome is a series of genetic mutations occurring in either potassium voltage-gated channels or sodium voltage-gated channels, just to name a few. This long QT syndrome can be congenital, which means genetic, familial, inherited, and I'm going to focus on that. It can be acquired, which means a patient could be on a drug, and that can cause long QT syndrome. In the case of the congenital, this is responsible for about 3,000 sudden deaths in children in our nation alone. Again, if you look at the bottom picture, you're seeing that there are many different voltage-gated channels that can be affected. What I'd like you to focus on is just the column that says, triggers lethal cardiac event. Notice that we read exercise, emotional stress, sleep response, and then others. And that sleep response is basically arising from sleep. It turns out that that's a sympathetic moment. You know, the alarm goes off, womp, 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 womp. Even when they show commercials and you hear the alarm going off in the commercial, doesn't that make your heart start to race? Same thing in these children with channelopathies. They're experiencing a stressor, some sort of acute response, a sympathetic response, maybe jumping into a swimming pool where the pool has just been open for the spring and the water is a little bit frigid. Well, what happens is there's a sudden outpouring of sympathetic neurotransmitter, norepinephrine, and for whatever reason, there's going to be a problem with either repolarization, if it's a potassium channelopathy, or depolarization in the case of a sodium voltage-gated channel. So when we're determining a long QT, we have to do a Bazat's correction. So QT with a correction has a subscript little c. So long QT little c. It equals to your traditional QT interval divided by the preceding R to R interval. We actually calculate this long QT by doing a correction. Well, that happens in long QT syndrome, and what we see is basically a series of early after depolarizations. I know that sounds funny. This happens during the plateau phase in phase 3. In the plateau phase, which is phase 2, we can also see some of these problems, like I said, in phase 3. What happens because of this genetic mutation, you can have previously inactivated sodium channels return to an open state. And this can reduce the net repolarization current. So the repolarization phase can take a long, long time. This can also happen with calcium channels. They return to the open state. And this means, essentially, especially with the epinephrine, norepinephrine release, a huge amount of sarcoplasmic release of calcium. I'll remind you, there's a sodium-calcium exchanger. The sodium-calcium exchanger exchanges 3 sodium into the cell for every calcium coming out. Well, if you have a large amount of sarcoplasmic reticulum releasing calcium, then that means you're going to have a lot of calcium moving out of the cytosol through the exchanger. And if it's moving 3 sodium into the cell, for every calcium coming out, that means we're going to have a lot of inward movement of sodium, which means a very long depolarization. Again, the long QT could either be from a long depolarization or a long repolarization. The signs and symptoms of long QT syndrome include dysrhythmia. The child will have unexplained fainting or seizures, near drowning or drowning due to fainting while swimming. These children have genetic mutations leading to faulty voltage-gated channels where they don't inactivate, deactivate, or activate correctly. What happens is they end up having their heart stop because of this very, very long time for depolarization and or repolarization. Beta blockers may work. They may not. Depends on the genetic mutation. The beta blockers traditionally help with mutations in the potassium channels. And if they don't, then that usually tells the physicians that it's a problem with the sodium channels, and they need to try a different arsenal of drugs. Again, the idea is to block the sympathetic response. In June of this year, 2013, one of my best friends growing up as a child, his 14-year-old son was on a vacation and dropped of a heart attack in front of the mother and his friend that he was vacationing with. Thankfully, the mother was a nurse. She resuscitated him. This child now has a defibrillator in his chest, cannot play sports anymore, and he's 6'3" and he's only 14. He had a very promising athletic career, and he's on beta blockers, and his life has completely changed. So long QT syndrome is frequent enough and noticed enough in these days that many high schools now require the children to get an EKG before they're allowed to play any athletics. And a student of mine over this past summer, she was getting her EKG to play soccer for the Saddleback school team, and she was diagnosed with long QT syndrome. It's time to start a different type of cardiovascular problem, shock. And I'd like to tell you in general what circulatory shock is. This is a generalized inadequate blood flow to the body, and I need you to know that definition. That means all tissues of the body are not going to be very well perfused. There are three basic ways where you can get circulatory shock. It can be because of hypovolemic conditions, meaning severe dehydration, resulting from excessive sweating or diarrhea or hemorrhage. It can be because of vascular reasons, meaning that the blood vessels are not putting enough pressure on the blood that's inside them. Or it could be because of cardiogenic reasons, meaning that the heart is not acting as an effective pump. On the next few slides, I'm going to tell you about the different types of shock, how we can have 4 stages of shock that were based on studies using 6 groups of dogs that were bled out for various times. I'm going to tell you about progressive versus non-progressive shock and reversible versus irreversible shock on the next few slides. This graph was generated with data from a very morbid experiment. First of all, there were 6 groups of dogs here, in Roman numerals numbered 1 through 6. The dogs were bled out, and each group there were multiple dogs. They were basically bled out for a certain amount of time. If you look over here on the x-axis, it says time in minutes. If you look at the 0 time, that's the starting time. You can tell that each group of dogs was bled out for different times to drop blood pressure to varying degrees. Some only had minor blood loss, meaning that they only bled out for just a short amount of time. And if you look at group 6, well, they really were bled out. They only had 20% of normal blood arterial pressure. This experiment was done to determine the different phases of shock. So the first phase of shock is just minor hypovolemia, because the bleeding out was minimal, for example. And then the second phase of shock is called non-progressive and compensated. Well, this is now where you've been bleeding for some time and where you do have a remarkable reduction in blood volume and therefore blood pressure. Your baroreceptors, your sympathetic nervous system, and even your endocrine system are going to respond and compensate. So if you want to look at this, we look at dog groups 1 through 3 in black. They were bled out sufficiently enough where their baroreceptors detected less mean arterial pressure through less stretch. Therefore, they sent fewer action potentials up to the brain, the medulla oblongata, and this resulted in a sympathetic reflex in the medulla oblongata, which of course means an increase from the cardiac acceleratory center. There was an increase in chronotropy and inotropy, and also an increase in vasomotor activity, which means more pressure put on the blood inside. Now, the third phase of shock is called progressive, which means the patient is getting worse, and their own baroreceptor, or central nervous system ischemic response, is not compensating, and they need medical intervention. This type of shock can lead to the fourth phase of shock, which means progressive and irreversible. Now the patient is getting worse, and any intervention is not going to be successful. Oh, they might improve for a while, but they're going to ultimately come to a vicious cycle, and it's not compatible with life. The dogs in groups 4 through 6, shown here in red, over time, it looks like their mean arterial pressure did improve. It looks like the baroreceptors, central nervous system ischemic response, did try to rally and bring them back. But ultimately, they had progressive and irreversible shock. Again, the experiment shows us the fine line between non-progressive, compensated shock versus progressive and irreversible. Just to do it again, progressive hypovolemic shock, or cardiovascular deterioration. The term progressive shock means that rather than recovering from shock, our victim gets worse. Because of the lack of nutrients and oxygen arriving at the myocardium, cardiac activity is being depressed. The heart is already hypoxic, and sympathetic vasoconstriction of the coronary arteries makes the situation worse. That means even less oxygen to the myocardium. The vasomotor center, or cardiovascular center, eventually fails because it is not getting enough oxygen due to the restricted central blood flow resulting from sympathetic vasoconstriction in early shock, in the first 10 to 15 minutes. With reduced tissue perfusion and exchange, we begin to see thrombosis in small vessels due to sludge blood, due to increased acid from the tissues. This increase in acid, a decrease in pH, causes circulating cells to agglutinate and clot. Should prolonged hypoxia occur, hours, increased capillary fluid permeability ensues, and fluid begins to transudate from the capillaries. As blood flow continues to decline, we see generalized cellular deterioration and tissue necrosis. Despite all of this, it is still possible to retrieve this patient from the brink. They may suffer some permanent damage to the myocardium and other tissues. In irreversible hypovolemic shock, now we're talking about a no-win situation. We treat the victim for shock, and we may even be able to normalize cardiac output and blood pressure with aggressive fluid therapy, but all to no avail. With lack of myocardial nutrition and severe depletion of ATP, the deterioration of the myocardium is extensive and irreversible. Due to acidosis, we see extensive and irreversible clotting in the capillary beds and widespread tissue necrosis. Now, to continue on with this idea, this is another way of representing progressive and irreversible shock and why it is a vicious cycle. Now, death doesn't have to occur very quickly. It can be in a few minutes, but it can also take a few hours. Even if a patient receives a transfusion during irreversible shock, the cardiac output could go back to normal for short term, but it's not going to be good enough. There's too much cellular damage and the person ultimately is going to die. That means they're getting an inadequate supply of blood volume. That means that they're going to consume all of their cellular oxygen as the end electron acceptor at the end of the electronic transport chain. The oxygen is going to be depleted. That means they won't be able to make ATP through oxidative cellular respiration. That means cells will rely on anaerobic means to generate ATP, which we know is not very robust. The cellular demand for ATP will outmatch the ability for the cells to regenerate it. That means that the cells will use up all of their ATP. It will be hydrolyzed to ADP, adenosine diphosphate, and that will be hydrolyzed to adenosine monophosphate, and then finally hydrolyzed to just adenosine. Adenosine can be released from the cells, and when released by highly metabolically active cells, we know that this is a signal for the arterioles in a capillary bed to vasodilate. When that happens, that's going to lead to increased capillary permeability, increased capillary diameter, dilation. This is going to lead to pooling of blood and will only exacerbate the problem of having reduced blood pressure. That means less perfusion in general. Again, a vicious cycle. The other problem is that adenosine, once it's leaked from the cells, it's converted into uric acid, and the uric acid cannot re-enter the cells. That means the cells have to remake adenosine, and they can't do that in a fast enough process, even if the person were given a transfusion. So down here in the bottom picture, you're seeing in red, a person has had a hemorrhage. You're seeing their cardiac output drop as a result of that. And then you're seeing a progressive shock. And you're seeing that the patient's baroreceptors are trying to rally, and their cardiac output goes up a little bit. But it's still no more than 40% of normal. Then you're seeing that they're starting to go into irreversible shock down here at the bottom. So they're progressive and irreversible. And you're seeing that they're given a blood transfusion, which helps increase their cardiac output for a while. But because they're in progressive, irreversible shock, that transfusion doesn't help. Again, the leaked adenosine from the cells that were already damaged has already occurred. Everything I have told you can actually be put into this flowchart. If you look up here at the top, you're seeing decreased cardiac output, say from a severe hemorrhage, a decrease in arterial pressure. That means a decrease in systemic flow. That means tissues everywhere not being very well perfused, and the cardiac tissue, as well as everywhere else, is being poorly perfused. The cardiac nutrition and other tissues are not getting adequate nutrition. It also means that if you don't have adequate blood flow, that the platelets are having way too much time to interact with the endothelial cells. This means that you can have intravascular clotting. If blood starts to clot, and you follow that arrow on the right-hand side, it means that you're only going to exacerbate venous return. It's only going to decrease even more. With decreased nutrition, followed that downward decreased nutrition in general, it means decreased nutrition of cardiac muscle and the brain as well, but also decreased nutrition for the vascular system. And I'll remind you that blood vessels have 3 tunics, and that tunica media, that's living smooth muscle. That means it needs nutrition as well. So you're going to have decreased nutrition to the vascular system. Basically what this means is that we're going to have the tissues depleting their ATP, and that means the release of adenosine from the cells. That's what they're talking about with decreased nutrition in the vascular system, leading to vascular dilation and increased capillary permeability. It's the adenosine leaking out, and that's what they're talking about, and that means that with increased vascular dilation and increased capillary permeability, the flow of blood, or lack thereof, is exacerbated. That's decreased venous return, and if we have less in, that means less out. So we're going to have progressive cardiac depression, meaning the heart is getting weaker and weaker as a pump. Now I'd like to go through individual examples of shock. Again, there are 3 ways that we can get circulatory shock. It can be because of volume issues, vascular issues, or the heart not being an effective pump. Let's start with volume issues. Hypovolemic shock. Well, how can we get there? Severe hemorrhage, diarrhea, vomiting, and burns. All of those can lead to large-scale fluid loss. We could also put on there extreme sweating. Maybe someone was lost down in the desert. That would also lead to hypovolemic shock. So it's large-scale fluid loss. We're talking about the plasma or even whole blood volume being depleted. The effective circulatory volume is decreased. This can lead to hypovolemic shock. With a decrease in blood volume, the baroreceptors, if this is of course a non-progressive compensated shock, the baroreceptors are going to detect decreased stretch. That means fewer action potentials sent up to the medulla oblongata, and the resulting output would be an increase in the sympathetic nervous system. So the person is going to have a rapid but weak pulse. Again, rapid because of the sympathetic nervous system increasing chronotropy, and that means increased heart rate, but weak because they have reduced blood volume and pressure. The person's cardiac output during this time will be decreased, lower than normal, but hopefully the baroreceptor central nervous system ischemic response, as it's called in some textbooks, will be sufficient to compensate. They'll have cold, clammy skin. Again, this is because of the sympathetic response causing vasoconstriction of blood vessels in the dermis, and also leading to scant sweating conditions. So they'll have that kind of damp moisture type effect on the surface of their body. And the endocrine system, with the RAA system, responding to the angiotensin II synthesis. And that leads to the release of aldosterone and ADH. Ideally, in the next few days, hopefully the RAA system with ADH will compensate by having the kidneys retain more salt and water, and that will help restore blood volume and pressure back to normal. I'm still talking about circulatory shock, a generalized term for inadequate blood flow to the body. You'll notice I've switched to the second category in this slide, the vascular category. Now I'm actually going to give you a couple of examples where the blood vessels are not putting enough pressure on the blood inside. In this type of shock, vascular shock, it's not a problem with blood volume. It's a problem with blood vessels not squeezing on the blood adequately. First, I'd like to tell you about anaphylactic shock. This is an excessive allergic response, a type 1 hypersensitivity. What happens is, of course, the antibodies that are produced against the allergen, those IgEs, will bind to the allergen, and this will allow them to then dock onto the mast cells and basophils. These two cells will release copious amounts of histamine. And how will that affect our Starling forces in the capillary bed? I'll remind you, it's going to have two effects. It's going to cause dilation, venous dilation, and arterial dilation, and that means in the capillary bed, not so much systemically, just think local, that the hydrostatic pressure is going to go up. Now, systemically, the mean arterial pressure is going down, of course. Also, in the capillary beds, in the tissues, in addition to the hydrostatic pressure going up because of blood pooling, we're also going to see that the histamine affects the KF, the permeability coefficient, and that means the capillary bed is more leaky. This means that the plasma will leak into the tissue, and we're going to see edema. This is going to exacerbate this type of shock because initially it's a problem with the blood vessels having excessive dilation, but then ultimately it can also lead to hypovolemic issues because of the massive fluid loss into the tissues. Sticking to the vascular category, there's another way we can have a reduced squeeze on the blood by the blood vessels. This is called neurogenic shock. How can a person get here? What is it in the first place anyway? It's basically the tunica media relaxing excessively. It's because it's not getting adequate norepinephrine. Let's say the epinephrine released by nerve endings. That's what this picture is showing you here, a postganglionic sympathetic fiber. Well, if the sympathetic nervous system is not releasing norepinephrine adequately, say because of too much spinal anesthesia or even too much general anesthesia, then the tunica media is not responding to norepinephrine because it's not being released, and that means failure to maintain vasomotor tone. If we don't have vascular tone, that is going to result in excessive dilation. That means decreased venous return and more pooling of blood and stasis. That means not flowing with adequate pressure. And another way you can have this, of course, in addition to anesthesia, is you can have brain damage. If a person has brain trauma to the medulla oblongata, that center in the brain, the vasomotor center, might be inactivated from that damage. Now, a separate category to this neurogenic shock, one that's just kind of fun, is psychogenic shock. This basically refers to a person seeing something so horrifically shocking that it paralyzes their sympathetic nervous system. And that means the parasympathetic nervous system gains too much control. With the loss of the sympathetic nervous system, even momentarily, there is profound vasodilation, loss of mean arterial pressure, less blood going up to the brain, and the person faints. If you look at old footage of Elvis Presley or even the Beatles playing, you see all these women swooning and fainting, right? So think of them. They're seeing something so shocking, so unbelievable to their brain, these icons in music, that these women have psychogenic shock. At least that's my fun example. Now, notice up here I am still talking about vascular shock, the blood vessels not maintaining adequate pressure on the blood inside. I am talking now about septic shock. This is the second most frequent cause of shock-related death in the hospital. It can be because of streptococcal or staphylococcal infections that can happen in the skin, or from infections in the kidney, or even peritonitis, where someone has had a bacterial infection in the peritoneal cavity. This happens a lot in women because their reproductive system is continual with the external environment. So ladies, we can get bacteria coming up through the vagina, through the cervix, to the uterus, to the uterine tubes, out through the fimbriae, and then the bacteria is in the peritoneal cavity, and it's in that peritoneal fluid. It's a warm, happy place for the bacteria, and they start to accumulate. If you remember your anatomy, bacteria can accumulate literally in these peritoneal cavities that are found around the uterus, and the excessive fluid from the bacteria accumulating can actually cause so much pain that these women have a distinct shuffle when they come into the emergency room. A lot of physicians call it the PID shuffle, for pelvic inflammatory disease. That's what PID stands for. The bacteria can release an endotoxin. The immune cells will respond to that endotoxin by releasing huge amounts of nitric oxide, which we know is an intrinsic vasodilator. This leads to excessive vasodilation. Well, if all the blood vessels relax, then that means we're going to have inadequate blood flow, and again, the blood will pool in the capillary beds. This can lead to edema. Again, an example of vascular shock, but specifically called septic shock, due to this excessive nitric oxide as a result of the immune system responding to the endotoxin. Oh, well, this is going to take some time to get through this slide. Bear with me. I'm going to spend quite some time on cardiogenic shock. This is the most frequent cause of shock-related death in the hospital. Basically, we're talking about the inability of the heart to efficiently pump blood. How can you have circulatory shock? Inadequate perfusion of tissues? You can have volume issues, vascular issues, or heart issues, where the heart is not being a good pump. These two pictures, these graphs shown here on the right side, are from Guyton and Hall. My pathophys students, I recognize you might not have Guyton and Hall, but I like these two pictures because they are showing compensation from a patient with heart failure. The bottom picture is showing you a graphical analysis of decompensated cardiac failure. In other words, the compensation is inadequate and the person is going to die. It might take them a few days, but they are in progressive, non-compensated shock. Okay, so let's pick apart the top picture. The top picture is a graphical analysis of heart failure and chronic compensation. It shows cardiac output and venous return curves for different states of heart and peripheral circulation. On the left side, where it says CO and venous return, The line showing here in red, just above the number 5, that's representing venous return. The other red line that says normal is representing cardiac output. Okay, where these two red curves pass through point A, that's the normal cardiac output and the normal venous return. Therefore, where they intersect, the normal state of the circulation is a cardiac output and a venous return of approximately 5 liters per minute. And you'll notice down at the bottom of the slide that that means a central venous pressure of about 0 millimeters of mercury. That's our normal. Now let's say the person has an acute heart attack. I want you to look at the blue line. This blue line represents the first few seconds after an MI. That cardiac output falls to a very low value. Again, we're looking at the blue curve. The venous return has not necessarily changed. It's a problem with cardiac output. The heart is not pumping right. So where the new cardiac output curve intersects the venous return curve is now at point B. That means central venous pressure has risen to 4 millimeters of mercury because the heart's not ejecting that blood. It's damming up and the cardiac output has dropped 2 liters per minute. This is now going to affect venous return, of course. Now we're going to talk about, hopefully, again, we're talking about compensated heart failure. We're going to have the central nervous system ischemic response, the baroreceptor response. They're going to detect less stretch, send fewer action potentials up to the brain, more sympathetic output. Within 30 seconds, the sympathetic nervous system becomes active. Cardiac output and venous return, their curves are going to be elevated as a result of increased activity of the cardioaccelatory center of the medulla oblongata. That means increased chronotropy and inotropy and increased vasomotor activity. More pressure, more squeeze put on the blood vessels, on the blood inside. We're going to see these new cardiac and venous return curves equilibrate at point C. That means cardiac output has gone back up toward about 4 liters per minute. Now, that's still not 5 liters per minute. Over the next few days, we're going to see the cardiac output and venous return curves go up even more, but also the renal compensation system. Again, the RAA system. The kidneys are going to respond to the aldosterone, NADH, and angiotensin II. This will lead to more retention of salt and water, more blood volume, and that means mean arterial pressure will go back to the new equilibrium point, point D. Cardiac output and venous return are restored to a normal value. In the bottom picture, we can repeat this scenario, but now we can show decompensated cardiac failure, meaning the person is not compensating well at all. So point A, if we're looking at this graph, is right after the heart attack. Cardiac output is below normal. The black line that you're seeing going all the way across is titled Critical Cardiac Output Level for Normal Fluid Balance. We see point A is below that. Cardiac output is low, but venous return has not been compromised at this point, not immediately after the heart attack. We see the cardiac output is about 3 liters per minute. Then we're going to see autonomic compensation. That would be the sympathetic nervous system response. That means more vasomotor activity, more venous return, and we see this in point B. We see some return of cardiac output. Very quickly again, within 30 seconds of the heart attack, the cardiac output goes back up to about 4 liters per minute. This cardiac output is still too low for the kidneys. Therefore, the kidneys will retain more fluid, more salt, and water through the RAA system. We see on the second day after the heart attack the patient's cardiac output improves a little bit to 4.2 liters per minute. But if this was a severe myocardial infarction and the heart just is not recovering well from it, during the next few days the cardiac output never quite rises enough to reestablish proper renal function. So fluid continues to be retained. The kidneys respond with the RA system with more and more salt and water retention. And we see that the venous return is going to shift, and we get these new points D, E, and F. we are seeing that the cardiac output is reducing instead of going up. This decompensated results from cardiac output never rising back to the critical level that the kidneys need. They need 5 liters per minute. It's just not being adequate. The heart is not generating enough pressure. How can we help this person? Well, if they're in progressive shock, but they're clearly not able to compensate, if it's progressive but reversible still, meaning the medical intervention could help, we could help this person with digitalis. That could lead to greater inotropy but reduced chronotropy, and now the heart becomes more effective as a pump. The kidneys will respond to that increased pressure now because it's adequate for them to filter the blood volume. The extra blood volume that they were retaining, they will eliminate that extra fluid, and this is called diuresis, meaning increased urinary output. I think this is interesting. I wanted to show you a few slides of different types of heart conditions that lead to cardiogenic shock, where the heart is not being an effective pump. The first picture up here, you're seeing large spacious ventricles in the heart, and this is dilated cardiomyopathy. There is increased hypertrophy, although it looks like the heart walls are very, very thin. In this case, the heart remodeled excessively, and it is dilated, which means large ventricles, but there's still hypertrophy. The overall mass of the heart has gone up. So it's not because it's thicker, it's because the cardiocytes have gotten longer. That's how they've increased their muscle mass. We don't know the chemical signals yet that cause cardiocytes to remodel this way, but they increase in length instead of width. If you compare this to the bottom picture in myocardial hypertrophy, now the chemical signals are telling these cardiocytes to remodel in width and less in height. This type of remodeling occurs with too much afterload, meaning too much blood pressure or hypertension. For whatever reason, this hypertension stimulates cardiocytes to remodel with greater width and less height. That means they are now infringing into the ventricular space, and that means less opportunity for filling. Less blood into the ventricles means less blood out, and that means cardiac output will decline over time. Cardiac reserve is how much your own personal cardiac output increases above your normal cardiac output. The difference between how much you could, when exercising, have for cardiac output versus how much you normally have at rest is called your cardiac reserve. If you look over here in the graph, the first bar in the bar graph shows normal, which means a person can have about 400% cardiac reserve, and then a trained athlete can reach a lot more than that. But then you're seeing other types of coronary disease, valvular disease, etc. And that can really impede how much cardiac reserve a person has. We usually test how much a person has by doing a cardiac stress test or a treadmill test. We put the person on the treadmill, we start to increase the speed until we see that person exerting themselves trying to keep up with the treadmill, and we might start to see an ST elevation on their EKG. It basically is telling us how sub-threshold they are. It's just another way of saying how much cardiac reserve they have. When they start complaining about the dyspnea, shortness of breath from the ischemia, start to complain about muscle fatigue, and they have an excessive increase in heart rate, when we start to see all that happening, we stop the test. That's when we know we've pushed them to the point where we know they no longer have cardiac reserve. Well, how do we treat shock if we can treat it, or when we're intervening? With shock, a person has reduced perfusion of the tissues. That means circulatory shock. Is it because of hypovolemic reasons? Vascular reasons? Do they have sepsis? Is it a heart problem? Well, how we treat them depends on the condition that got them to that situation in the first place. First of all, you should put them in the head down position, of course, the recovery position, feet up, head down. If they are in hypovolemic shock, obviously blood and plasma transfusions would be the go-to. If it's dehydration from extreme sweating, you can give them electrolyte solutions, a saline drip, because it's not a blood quantity problem from the red blood cell point of view. They don't need more red blood cells. They need more fluid in the plasma department, so that's why we can give them a saline solution. We could also give them a dextran solution, which is a sugar solution, instead of blood products. What about sympathomimetic drugs? Can we give them epinephrine? Well, that doesn't always help. For example, someone who has hypovolemic shock, their central nervous system is already responding. Their blood vessels are already trying to constrict and put pressure on the blood that's remaining, but it's an inadequate blood volume. So sympathomimetic drugs aren't going to help because this person's central nervous system is already responding. But they would help with vascular shock, where the blood vessels are not putting adequate pressure. In the case of anaphylactic shock, sepsis, neurogenic shock, then yes, epinephrine would be helpful. Oxygen? Do they need oxygen? Nah, that doesn't really help them. They have a problem with blood flow, not the lungs, not gas exchange. I mean, we don't typically give them oxygen, but if they do have some sort of underlying lung problem, then yes, we would. But it's typically not helpful with respect to shock. Glucocorticoids like cortisol or other glucocorticoids, could we give them those? Yes, those help strengthen the heart. It might be very helpful to give these for cardiogenic shock. These glucocorticoids aid in glucose metabolism. Again, we're trying to help with the whole adenosine issue and ATP and anaerobic production versus aerobic. So the glucocorticoids can help in that perspective with glucose metabolism. Okay, that concludes our lecture on cardiovascular problems. I hope you enjoyed it.